Thank you. And we are moving to the next keynote lecture. It is my pleasure to introduce Huub Van Hedel. Huub Van Hedel is the professor of neurorehabilitation. He is the head of research and member of the executive board of the Swiss Children's Rehab in Zurich, Switzerland. He received his training as a physical therapist and as a biomedical health scientist in the Netherlands. His research interests cover neurorehabilitation, outcomes assessments, motor learning, and brain reorganization. He has a particular interest in the development of rehabilitation robots and exergaming and the improvement of the personalized application of these technologies. He currently chairs the Advanced Robotic Therapy Integrated Centers, the Arctic Network. His multi-professional team won various prizes during the past years. He authored about 100 publications and is an editorial board member of the famous journal NNR, Neurorehabilitation and Neural Repair. Professor Van Hedel, today it is a great honor for the EACD to welcome you on stage and to speak about the personalized application of rehabilitation technologies in children undergoing neurorehabilitation. The audience is yours.
Dear Mr. Brochard, sincerely thanks. I hope, is my screen available now to everyone? Okay, so good morning, good afternoon, good evening, or even good night to all of you. I feel really honored, and it's a privilege for me to present this topic to you. It's based on some of the experiences that we have made in our center. First, a little picture of our center. From the outside, it looks like a conventional rehabilitation center, and indeed, it also is a conventional rehabilitation center. It's nicely located on the green countryside. Within it, our children and adolescents of various diagnoses, mainly with cerebral palsy, but also with acquired brain injury, undergo an intensive inpatient rehabilitation program. So we provide all of the conventional therapies that are needed there, the physiotherapy, the occupational therapy, the speech and language therapy, the sports therapy. We have nurses and physicians available 24 hours a day, 7 days a week. And it's really a nice place to work. And it should also be a nice place. It's a familiar environment, and we think this is really important for these children to train. What is a bit special about our center is that during the last years, we have started to include technologies and complement our conventional therapies with these technologies. So a bit more familiar already are these some of the devices like the Erigo, the Locomat, or the Andaga to train walking or even overground mobility. Recently, we were able to install a Ryzen system where we have also the possibility to provide floor projections for a playful environment. Our occupational therapists, some of them grew really fond of all kinds of technologies, and it's now that we have several systems available that they use, and even our sports therapy has started now to include some of these newer technologies into their training programs. There are a lot of reasons to include technologies in your center. We can all hear our managers saying it might be more efficient, you can train more children. I think in pediatrics, that is not completely true. Of course, the parents who ask for new kinds of technologies, and of course, we listen to our parents. The kids, of course, like it. But from a therapeutic point of view, I think there are two very important issues. One is that we think that we can increase our dosage per training session, our intensity. And if I look at some of the results of from a previous study, for example, we could actually show that when these children were in this Armeo spring device, which is not a motor-driven device, it has some springs in it to support the arm. And these children performed over 3,000 point-to-point movements and opened and closed their hand within 70 minutes of game playing that we divided over 3 sessions. So this is a huge amount of training. And also, if I speak to our therapists who perform the Locomat trainings, you can say that at least 1,000 to 1,400 steps per session can be done. Now, we all know from motor learning, high dosage and tendency is an important issue. One can question to some of these devices how active these children actually participate in this. I will come back to that later. But at least it seems really that with these technologies, we can provide a high intensity of training. In addition, of course, we have the exogames, the virtual reality, that some of these technologies can be a combined. And these have several advantages, of course. They provide augmented feedback on the knowledge of performance or knowledge of results of the kids. There are some interesting motor learning studies showing that with this external focus of attention, it's actually possible to improve your performance. And the main thing here, again, this motivation, this training playfully. And there's this older publication from 2006 from Bryanton already showing that if children had to practice some foot tasks, that both children and the parents thought it was much more fun to do with a virtual reality task. And also in an older study from our group where we developed a small game for the Lokomat, we actually could see that the motivation increased. That was not really shown in our likelihood scores that are here in this table. They're actually not so much different between having a game or having a therapist motivating you or just watching a DVD. But if we ask the question, how would you like to train the next time? Then 70% of these children actually responded they would prefer the game. So over time and over our experience, we must also say that this is also a bit of half a truth. Of course, these kids like these games, but if you're for a longer time in a rehabilitation center, it just occurs that these games become also somewhat boring. And some qualitative studies have also shown that at the end, it's still the combination of the therapist with the technologies that make this training so playful and so interesting over time. Indeed, motivation is important. And what is known from literature is that children with developmental disorders appear somewhat less motivated and more passive in their playing behavior. Or like the therapist likes to say, they do not like to challenge themselves so much as what we know from peers. And I think this is something, of course, where rehabilitation is always about pushing your limits a little bit further, try to explore something new. Now, the use of technology is growing, both in research, if you just added in PubMed, what you see here, but also in clinical application. But still, I think, especially in a center like here, where rehabilitation technology has become part of daily life routines, we must consider that most of the technologies are not there for all kind of therapists. I do not know a lot of therapists who can say, this is part of my daily life therapy, or my therapy looks sometimes like this. So what kind of programs do we offer? We have this intensive inpatient program. I would like to point out again that most of these training sessions, so this is a weekly program of one of our patients here, is still filled with conventional therapies. And we add these robotic trainings to also a bit in line with the ICF. We think there's most of these robotic trainings improve your body function, but you still need the conventional therapies to make a transfer in daily life relevant activities and participation. We also have some outpatient programs where we focus a bit more on the robotics, but still we would like to combine this with conventional therapies and also with sports therapies. And the numbers of patients who have shown interest in these programs is growing during the last years. And if we look at our first data very carefully, it also seems that indeed these make nice progress. But this is, of course, not part of randomized controlled trials. If you look a bit more carefully and you start to think, how can I implement these technologies? There are actually some things that you need to think of. And for example, we are here in a luxurious position that our patient trainings go about 45 minutes. That means for a system like the Lokomat, where you actually need some time to put the patient into the device, make the settings, and then actually perform the training, you need to have a program that allows this also. If you have programs where you have like 30 minutes for the patient to enter and also to leave, then I guess this is a program where a device like a Lokomat might not be well placed. You need some time to prepare the Locomat. In our case, this is nice because in absence of the patient, the therapist can already prepare the system. And then when the patient is there, you need some time to mount the device to the patient, slowly start a training, and actually have the training for 25 to 35 minutes, and finally remove it. Of course, for a lot of other technologies, particularly those who are not the so-called exoskeletons, where you actually have to fit the patient really into the technology, the times, for example, to mount the device to the patient is a lot shorter, and you can also work with other training with Ollie daily programs. It's always a bit of a question, who will perform the trainings? In our center, which is relatively small, we have like 44 beds, 250 employees. We actually have a small select group of therapists working with these technologies. Why? Because in this way, these therapists will train a lot of patients and they become more experienced and more efficient. And also we think it improves the quality of the trainings when they apply it like this. There's a little positive economical part that for training to new devices or updates, of course, you have some less people to train. But there are also a lot of negative aspects to this. So as soon as you have smaller teams, it's also less flexible in planning in case of absences or anything. And if you have therapists who would mainly work with the technologies, over time, this becomes actually a bit of a motivational issue for the therapists, because they are used to treat all kinds of patients from very severely to relatively well functioning. And one thing is that this technology limits a bit your patient selection. So you have to really carefully think about your own setting and trying to find a way how you can best implement and who will perform the trainings for your patients. We have these in and outpatient programs, and in these brochures that we made, we also put the most important in and exclusion criteria. So we start with most of these robotic devices from an age of about 4 to 5 years. This is mainly to do, of course, for some of the devices, this is related to the anthropometrical requirements that you need for these devices, but it also often has to do with the cognitive ability of the children. Then there are some specific in and outcome criteria, but this is actually where slowly we get to the more important question, which would also be the topic of my talk. And that would actually be, yes, of course, these are nice in and exclusion criteria, but it seems that still a large group of children would profit from this technology. But the main question is at the end, which child might profit from which technology? And I formulated in my head also sometimes like, do we actually understand what these technologies do? And our research has tried to tackle some of the little puzzle pieces that we try to learn a little bit better what these technologies do. So what happens in my head is that I start to think, when I see one of these devices, that I start to think, so which kind of patient might profit from such a device? And then I start talking to experts. And in the past, these were most of the therapists that train these patients, or it could be other physicians and others. Nowadays, we also include more and more patients and their parents, because they are also a very important group of experts that we need to involve in this part. And then, of course, we try to implement their knowledge into such a model, and we start testing some aspects of how we think these technologies work. And I will show you an example here. Until some years ago, we had, for the lower extremity, we had mainly these two devices. On the left, you see the Irrigo, which is a dynamic tilt table, which is for quite severely affected patients. You can verticalize your patient, and it allows to make some leg movements. And besides that, you see this Locomat exoskeleton, which consists of a treadmill, this bodyweight support system, and it drives and it guides the patient throughout movements. When we started thinking of what is needed, what kind of patients might be trainable with this device, we formulated this theoretical model We included the ICF. We looked a little bit, are we training here more on body function, on activity or participation? We started to look at what are the requirements to train with these specific devices. So for example, here with the dynamic tilt table, it would actually require a minimal consciousness state. And for a Locomat, an exoskeleton device, for example, in the old way, position controlled, the patient at least needed some potential for step initiation. And there were some minimal requirements for head and trunk control, as well as cardiovascular stability. Then when we started to talk, I talk now a little bit more on the Locomat, where we did a lot of research in, we first started to talk with the experts, and we learned from them a bit more indeed what these additional requirements might be. Or we also started to learn what kind of goals we actually see when we apply such technology to these children. And this was very fruitful. This was in collaboration with people from Munich who used the device for a similar long time as we did, but we also included orthopedic surgeons or other ones who we would like to ask, do you think this device can also play a role in the post-surgical procedure of your work? And what we also started to do is we started with some small-scaled experiments. I will not go into detail, but for example, one question was, if you have the exoskeleton device and the old-fashioned way, this position control, so the patient just follows the steps made by the robotic device, and then there came some newer cooperative treatments, so the patient actually had a bit of more freedom, a bit more the possibility to guide his own legs. We wanted to know, what does this actually mean for the patient? Is it possible that they indeed increase their activity of the leg muscles? Is it more strenuous for the cardiovascular system? But are they also still able to keep up a physiological walking pattern? And in the study that we did, indeed, we could show that some of these newer cooperative strategies enabled higher muscle activities, enabled a higher frequency of the heart during the training, but also much more patients found it more difficult in keeping a nice physiological walking pattern, which is important for the therapist, because depending on the abilities of the patient, the therapist should select the appropriate way the Locomat should apply these movements to the legs. To be honest, we have now two new technologies. One is the Undago, an overground walking device, as you can see here. And even more recently, we got this Ryzen system. And to be honest, we are still trying to find out how they would fit into this model. Where is their exact location? What kind of requirements do the patients need to have to train with these devices? And what kind of potential do patients and therapists see in applying this technology to the patients? I will show you some preliminary results of a first feasibility study that we've done with the Undago. The Undago is an interesting tool that allows walking over ground, but there is no guidance of the leg. So the patient already has to have the ability to make steps. There is a weight support system, and there are actually sensors, so the device can follow the patient. There are some different modes, like the therapist can control it, and you can just go in a straight line, or would really accurately follow the patients. And we are slowly collecting our first clinical experience with this device. Now, one thing what we noted when patients walked in the Undago was actually that they walk completely different when we compared it when they walked in the Locomat or on a treadmill. So one of the first experiments then that we did was actually we started to compare how they walked in the Undago and on the treadmill. And we were particularly interested because we noted that over ground they showed much more variability between steps than when they walked on this normal, not such a high-tech treadmill like Jaap Hala just showed you, but a regular normal treadmill system. And what we could see, these are now some stride times of 30 steps. You could actually see that the orange ones that belong to the treadmill are very consistent. In fact, if you compare it, it is more consistent than what healthy people would walk over ground. On the left side, though, you see that when they walk in the Undago, there is indeed a larger variability. We looked in addition to muscle activations, there there was actually not so much difference between these settings and also an interjoint coordination. And if we looked at over the group, I think it were almost 20 children and adolescents with various diagnoses that we tested, we could actually see that indeed in the Indago, you have a much higher stride-to-stride variability of the steps, and also the interjoint coordination is higher. So this means for a therapist that depending on what your treatment goal is, you might actually consider one or the other device, depending on the status of the patient, depending how well the patient can already control the joints during walking and things like this. What was also interesting to note were some of the comments of the patients. So some therapists reported that patients stated that they could train a bit closer to reality in Indago when they compared it to the training on a treadmill. And they considered it as a bit qualitative higher, and it required more concentration compared to walking on a treadmill. And I'll show you now some very brave slides because we're still working a little bit on this. But what we then actually did is we tested some of our patients walking in the Indago wearing this near-infrared spectroscopy cap. And we tried to see whether we could indeed see whether it would cost them more brain activity, more attention, or also more motor planning to walk around. So we looked at some of the hemodynamic changes that occurred in the brain blood flow. And the nice thing was that in some patients, we could indeed see that when they walked in Indago compared to on a treadmill, that there was indeed a higher activation of the supplementary motor area. On the other hand, the disappointing thing was that the hemodynamic changes of our patients merely did not follow the responses that you would normally expect, showing again that research in pediatrics in neurorehabilitation is actually very, very challenging. Now, our research for the upper limb is not so advanced. It's also for us a bit of a novel field. But I think we're also starting here with some first efforts in understanding a bit more of the technology. Initially, we looked at our devices, and we actually have quite a bunch over time because, of course, for the upper extremity, it's not just like walking around, but you're also much more interested in, do you need to train more proximal joints or distal joints or grasping movements or uni or bilaterally. Initially, we started to look at these devices and think of them, which of these devices can apply to a patient just by looking at the support of the device. So the Amadeo is a hand robotic device, and the Charming, this is a device that we made here in our center together with people of the ETH. These are both real robotic devices that have drives to move the different joints. And from principle, you can have a patient being passive and the device will be able to join, but you, of course, can also have some sort of assisted modes. Then there are some devices that allow a sort of support, but the patient still has to move the arms by themselves. So this Armeo device that you've seen before has like springs. The Diego device, it's a bit difficult to see, I apologize. Actually, it's like two strings that are being, where you hang in the lower arm of the patients, and they also alleviate the weight of the arm. So also children who cannot really move their arms against gravity are able to train and work with the device. And then there are several other devices that provide no physical support at all, but it's mainly that you use the movements of the children in combination with the games to provide playful therapy. Now, what our OTs then started to do is look more careful at these devices, and I give a bit of a short overview of some of them. And what they started to do is make a lot of thoughts on what kind of joints and also what kind of movements can you actually train with the technology. So this Charmin device that we made is actually possible to have shoulder, elbow, lower arm and wrist movements. But for the hand, there are not many possibilities, for example, for finger extension. You can squeeze in this pressure sensitive bulb, but there's not so much that you can train the hand for. It looks a bit the same for the Ameo Spring. Also here, you have support, not completely 100% possible, but you have support for the weight of the arm. You can train your shoulder, elbow, lower arm and wrist. And again, for the hand, there are fewer options. This Diego device from Tyro Motion, this allows, of one of the few devices, actually also bilateral training. It provides weight support. You see it now better on this photo. And what is a bit unfortunate is because you fixate the lower arm to the device, there's not really any possibility of additional training for the wrist and the hand. And finally, this NeoFact device, which is a sort of a sensor, and you can measure some bending and extending of the wrist. They like to use it particularly for the distal part. So if you start look more closer at these things, what kind of joints you can train, and they also looked at what kind of movements in the way occupational therapists speak with it. So if you can do some fine select finger movements, some grasping or transfer movements, we could now extend our model a little bit. And now it looks already a bit like this. So we have here the information on how much support the device provides, but also what kind of joints can I train. And also here, if you see it here, it's a bit light perhaps, but the possibility to test reaching movements or transfer movements or grasping movements, etc. What the occupational therapist then did, and I think this is a really nice way, because they started to look more at the exergames. We always think of these robotic technology devices and these games like, let them play and they will train a little bit over time. But they started to look at each of these games. And to be honest, these are now just the games for the Ameo Spring device. You see it already over 20. I'm sure that in the meantime, there are even newer developments. And they asked themselves the question, what goals can we actually train really specifically when kids use these exergames? And they formulated goals on the body function level, but they also looked a bit at the assisting hand assessment and tried to look at a bit more functional goals. And what they then did is that 3 occupational therapists independently from each other scored each game and determined what kind of goals actually can be trained. And this was a huge amount of work. And here you see just a summary slide of some of this. And it shows you that for each of the devices, they looked at the games and they actually provide you here with therapy practice-based recommendations on what kind of therapeutic goals you can train with these systems. They looked at goals like the active range of motion, training passive range of motion, but also endurance or selectivity, dosage of the movement, dosage of strength, whether you can actually train different sorts of grips with the system, and also whether it even would allow fine in-hand manipulations. And I think this knowledge is particularly interested for centers who start using such technology, because they could profit from the experience from the therapists from our center and see, depending on what kind of patient groups they have and what the requirements for the patients are, whether they might be able to select in advance already a bit of a device or the exergames that are needed. If we look at the AHA items, there's a bit of the same. They also scored all these games for general use of the assisting hand, arm use, whether they would grasp and release or fine motor skills, coordination, or tempo. If you would like to know more, tomorrow there will be a breakfast session and one of our OTs will dive deeper into this topic. I will show you it at the end of this presentation. Of course, also here, at the end, we start to evaluate whether these thoughts that we had about our model, our construct, might indeed be right. And this is this robotic device that we developed. In the meantime, we have made a feasibility study in about 35 participants. And what you see here is on top of the left, you see actually the therapist that defined for each of these 35 patients what would be an important therapeutic goal. So whether it would be training the shoulder for flexion or extension, elbow, etc. And on the right, you see actually how well the charming fulfilled these goals as defined by the patient. And in general, you can see that Charman was quite well able to fulfill, to train in these patients the goals that the therapist thought were important, except for the finger extensor, which is missing in this device. And of course, finger extension is for a lot of children quite an important issue. So this would be something that actually would need to be improved. What was an interesting finding also, I think this was actually placed here, it also fits a bit in line with our model. What was an interesting other observation actually was that when we asked the kids what kind of games they actually thought were most motivating, that the higher scores actually were quite an agreement between the games that the children thought were motivating and the games that the therapist thought were actually being the most adequate for this patient. So this is actually quite nice because it would indeed allow to have the most adequate training being combined with the most motivating games for these participants. Now, one thing that I have learned is actually that we have all kinds of thoughts about these technologies. We think that we know how it works. If you look at the commercial websites, actually the industry already knows how they work because you can train all kinds of patients and therapists improve. But it's not that easy. We think these technologies have quite some opportunities, but do not take anything for granted. I give you a very simple picture here. On the left, you see, again, our charming device. And we created a game in which it was possible to have like a support of the device where the patient could remain passive, and also a possibility to be very active, because we wanted to test whether indeed patients respond to the support system of the robotic device in the way we think it will be. And this was actually quite nicely done. I think these were results of this game where we looked at wrist extensor and flexor activity. And we see that in both, there were two different active conditions. Muscle activity was considerably higher than the green condition, which was the situation where the patient could remain more passive. On the other hand, though, we already had quite some years ago, we did a nice master thesis. And what we looked here was actually if we reduce the guidance force of the locomat, which is actually the force that would support the patient in making the leg movements, we would have think, of course, by reducing the guidance force, they would increase their muscle activity so we could make a more active training situation. And the astonishing results were here that no matter whether these children and these adolescents were diagnosed, I think it were between 15 and 20, walked with 100% of the guidance force, or with 80 or 60 or 40, there was actually no change in their EMG. And no matter whether we looked at the whole step, whether we looked at the stance or the swing phase, whether we looked at the, I think we had 6 different leg muscles that we looked at, there was no difference, not even if we looked at reducing the guidance force on one side, on both sides. So, of course, this urges then also to find some alternative ways to make the patients more active in this device. How can we improve the personalized application? And this is also now a very short overview of 2 new projects that are running. For one, in one project, we are working on an exogame to train selective voluntary motor control. So this game should be able to train an accurate motor control while reducing the simultaneously occurring involuntary movements. That could be something like mirror movements. It could be like synergies that occur. That could be like compensatory trunk movements. So we're trying to create a game that where the patient needs to be very accurate in its control, while it also provides an indicator as soon as an involuntary movement will occur. And what we have learned from the past is that we should learn more to our patients. So we started this project actually by interviewing patients in our center, and we asked them, what kind of games do you play, and what do you really like about your games, and with games do you actually play also for a longer time? Because what I showed you totally in the beginning was indeed these games increase motivation and compliance, but often over a long lasting rehabilitation period, this reduces. And there were several things that these children like best. So one of them was, for example, strategy. So being able to control parts of the game, making choices. And we looked at these rather carefully, and then started to, because we think this is important to keep up a long-term compliance of the children. We made a small-scale study because besides looking at how accurate control they could be, we'd also needed to learn more about what kind of feedback modalities would inform these kids in case an involuntary movement occurred. We did not really find anything in the literature, so we have a great lady here, Andrina Keller, who programmed these games, and she made some various changes in modalities. And what we found finally was that particularly an acoustic warning signal was perceived the quickest, the fastest by the children in this in this preliminary study. And then we finally created the definitive game, and we made a first feasibility study. And this game is now really particularly specifically developed for children and adolescents to train selective voluntary motor control. And we're now in the final phase, and I cannot show you anything because we're working on the final study protocol now, that we make a multiple N-of-1 trial to actually also investigate whether it is truly able to improve selective voluntary motor control. In another project from one of my postdocs, Corinne Ammann, she started to develop an extended reality application to train daily life relevant mobility tasks. And also here she took the approach, first talk to children and to parents. So she made focus group interviews and identified all kinds of activities in daily life that are considered by these adolescents and these parents of importance of walking around. And of the, I think, over 80 activities that the adolescents had reported, and also over the 80 activities that the adults reported she could find two major groups, and one was mastering obstacles. So the next step that she then did was we tried to look a little bit in what kind of technology would actually be used well. And to be honest, we from the research team and also most of the therapists, we thought these kids use augmented reality. Augmented reality means it's a bit difficult to see here on the picture, but you see actually the normal environment and you can project some objects in your normal environment. And we thought this will be appreciated by the kids because a lot of them have sensory impairments of the legs. They will not be able to see. They will be difficult to walk around in one of these really complete virtual realities where you really see nothing of your true environment. She did a very nice feasibility study, and the interesting things was actually that preference of the therapist at the end were a bit like 50-50, but patients really prefer the virtual reality. We had no issues whatsoever. Also in children with some larger sensory issues, they put the glasses on, they walked around, and it was great to see what they started spontaneously to do in this big room that we have, which is normally our gait lab, and that was now suddenly filled with some objects and things that she could think of. Now, by combining this knowledge, she now created a virtual reality scenario that includes actually several of these things, aspects that she derived from the focus group. We now use it in a virtual reality scenario, and I don't know, it's the only movie, I hope it works. So now it looks a little bit like this. So rather than that these children are in a large and empty room, they are in this environment. They can have different tasks. They need to look for certain objects, or they can feed. Oh, how's the animal called in English? I'm not really sure, but you can feed them melons or whatever. And the children really like it. It's very, very intuitive for them, even for those who have lower extremity impairments. So with these flashy movies, I would like to finish my talk. I have a couple of small take-home messages. I think it is important that after the initial hype, how extremely well these technologies would be, I think we're now in a realistic phase. I think we should consider these technologies as new tools for therapists. They have clearly advantages, but there are also limitations, and we need to learn these. I think it's important, if you're a center or a therapist, that you think carefully about what technology might actually the best for your setting. This is both to do with practicality issues, but also look carefully at what kind of patients that you actually treat on your daily setting. We need to learn to understand what the technology does, and we need to really carefully listen to patients and therapists and involve them really early, also in the development of new technologies. And this is not just meant for research groups. I think this is also a very important thing for industry that works in this. There will be huge challenges for us in the near future. These technological developments are exploding. They are developing so rapidly. It will be a major challenge for the clinical field to keep up with these. And there's still some issues that I think that most technologies are still made for those patients who are actually already a bit better. And for those really severely affected patients, I think we're still missing some promising technologies that also could improve the functions in this patient group. So with this, I would like to thank a lot of people, the collaborators during the past years, but especially the people in my research team, the foundations that provided financial support for the work that we do. And if this talk made you a little bit more curious, there will be a session a little bit later this evening, also focusing on technology. And tomorrow morning in a breakfast session, I have some physiotherapists and OTs who will also show you some patient examples of how we apply these technologies to our patients. Thank you very much.
Thank you very much, Professor Van Hedel, for this very, very nice talk. So we don't have so much time for questions. I think the session is out at in 1 minute. Maybe can pick up 2 questions grouped in one. The first is could you think of possibilities on how this technology could help to increase participation? And the second comes with this one is, what are your thoughts about the value of these technologies regarding the training of everyday life activities?
Yes, these are 2 very good questions. So I think first, participation by itself. Of course, there is also an increase in a lot of other technologies that can be used as assistive devices in daily life. And I'm not just speaking of motor function. I also think then of communication technologies and things like this. I think here technology can actually be also for the more severely affected patients a really add-on. And how far the technologies that we have here might be able to translate into participation in daily life, I think that's still a bit questionable. There is interesting research from large meta-analysis in adults with strokes showing that if you apply these robotic systems within the first 3 months after stroke and those patients who are initially unable to walk, that they actually increase the chance of being later showing independent mobility. Unfortunately, the number of RCTs in our pediatric field is much smaller. We have issues that a lot of our patients, for example, those with cerebral palsy, do not show spontaneous neurological recovery. So we have a bit more challenges here in showing finally how effective these technologies can be. I hope that answers a bit the question.
Yeah. So I don't know if we have more time, but if it doesn't stop, I will continue. So I have a question from the president of the conference, Marek Czorziak, and there is 2 questions about the dose. So to make it simple, what are your recommendations with the dose in robotic therapy? I would say in general. This is also a question from Jill Hilscock. Dosing is one of the most important topics, but there is also error-based learning. For example, when you do point-to-point task and treadmill. So how do you manage with this dosing and potential error?
That's a good question. I think what we do here, I do not know whether that finally would respond to the question, but what we do here is that the training in a robotic therapy is very much under supervision of the therapist. We never have patients trying to train alone. And the therapists pay from onset on attention that the movements that are being practiced are actually the physiological desired movements that they would like to see. Indeed, the difficulties are, and this is a bit the case with some of the technologies, that you have less control over how the patient moves. And then, of course, you can get into the situation that you might train non-physiological or compensatory movements, which might later result in secondary complications that you actually want to avoid. This is one of the reasons why in our center, the robotic therapy has not become more efficient from a management perspective, because we still have always a one-to-one situation.
Thank you, Malgorzata. I think we have time for one more question if you want to go on. Yeah, and this will be the last I hear that this should be done. Thank you. Malgorzata, you want to go?
Okay. There was one very interesting question about the participation in such rehabilitation of children with mental disabilities who cannot very well follow the instructions or understand them even. How do you resolve such problems?
This is a very difficult question. For some points, some of these devices, like these exoskeleton devices, provide the possibility to train with these children, even if they might be not, like very cooperative or know exactly what a trained movement is. This could be some advantage of these devices that actually, how do you say that, where the patient is really being mounted into, so the device learned its child some movements, and you might hope that over time some of this will be included into the system. But this is a continuously ongoing discussion also in our case. Would we train these patients? Often it is the case that parents really want us to train them. The therapist might actually have some issues with it, particularly if they're not able to reply whether they experience any discomfort or pain. This is a challenging question. I have no good answer to it at the end.
Okay, thank you very much. So we end up the session. Thank you, Sylvain. Thank all the keynote lecturers.